Okay, Dr. Ezekiel Silva, have you registered representing the Texas Medical Association, and I have you for House Bill 44, is that correct?
That is correct, Mr. Chair.
Thank you. You may proceed.
Thank you. My name is Zeke Silva. I'm a diagnostic and interventional radiologist. I practice in San Antonio. I am also chair of the TMA's Council on Legislation, and I am speaking today on behalf of the TMA, and we are speaking in support of House Bill 44, the Life of the Mother Act. We thank Representative Guerin for filing this bill because we at the TMA believe that this will enable us to achieve the goal of providing the best care possible for pregnant women in this state, especially those facing the difficult circumstance of a complicated pregnancy. Our commitment is deep, our commitment is long-standing, and it will be maintained forever. In recent years, it has become apparent to our physicians that there is the potential for adverse determinations based on our decision-making, specifically the potential for fines, the potential for loss of our medical license, even the potential for jail time. As physicians, we're doctors, we're not attorneys. We have to rely on the guidance from others, and that guidance has come from a number of different sources, including the state, including local institutions, even our local medical staffs. Shortly, you'll hear from some talented attorneys who will speak to the legal aspects of this bill and the difference that it will make. But from the physician perspective, I want to stress, our focus is absolutely making sure that we can provide the best care possible for these patients, and the TMA believes that House Bill 44 will be an important step to enable that goal. It will allow our physicians to use their sound medical judgment, their expertise, and the trust that patients have in us, provide that care when we believe that the life of the mother, major bodily function has a potential to be compromised, including reproductive health, that it will enable effective communication with the patient and those involved in her care, and that will also enable us to do so in a timely fashion. There's a CME component. As physicians, we are lifetime learners. Medicine, maternal health, public health is dynamic, and we are committed to that CME, but also learning from this experience going forward. Members, as a physician, as a diagnostic radiologist, as someone who reads obstetrical ultrasound in the middle of the night and oftentimes is the first one to realize that this woman's pregnancy is compromised and potentially challenged, I understand the complexity of this decision-making, the complexity of these patients, and speaking for 59,000 physicians and medical students, I urge this body to pass House Bill 44 to enable us to do what we've always done, which is provide the best care possible for the pregnant women in our state. Mr. Chair, Vice Chair, thank you.
Thank you, Dr. Silva. Members, I believe we will work through this panel and then open for questions when we're done. I want to remind everyone testifying today, we do have a 2-minute time limit. Alex over here has the timer, and I don't know if you can see the lights or not, but I will let you know when you reach that 2-minute mark with your testimony. The next one. Okay, Heather De La Garza Barone, have you listed as testifying on behalf, you are the Associate General Counsel testifying on behalf of the Texas Hospital Association, and you are for House Bill 44, is that correct?
That is correct.
Thank you. You may proceed.
Good morning, members, Mr. Chairman, Madam Vice Chair. Thank you for allowing us the opportunity to testify today. Again, my name is Heather De La Garza Barone, Associate General Counsel for the Texas Hospital Association, and I'm testifying on behalf of our membership today in full support of HB44. THA strives to be an advocate for accessible and high-quality health care. We work to promote a healthcare delivery system that provides the right care at the right time to patients who come through the hospital's doors. We strive to ensure that patients are given the best medical care in compliance with all applicable laws and regulations. Since the Dobbs ruling in 2022, Texas hospitals were overnight faced with navigating multiple abortion statutes that contained conflicting definitions and undefined terms. This allowed for differing interpretations about when and how intervention regarding pregnancy complications could take place. HB44 makes important and necessary clarifications that will help Texas hospitals understand how each of the abortion statutes are expected to interact with one another. It allows hospitals to continue to support our physicians treating our pregnant patients without fear of civil liability or criminal prosecution. We want to express our immense gratitude and appreciation to Representative Guerin, his staff, and all of the co-authors of HB44 for filing and supporting this important legislation and allowing hospitals to be a part of this important discussion. We also appreciate all the other stakeholders for engaging in meaningful and important dialogue, allowing us all to come together to reach a vital compromise to protect Texas patients. Thank you for the opportunity today, and I'm happy to answer any questions.
Okay, thank you. Okay, we have Lisa Kaufman. Have you registered testifying on behalf of Texas Civil Justice League, and you are for House Bill 44, is that correct?
That's correct.
Thank you.
Thank you. Good morning, Mr. Chairman and members. My name is Lisa Kaufman, and I'm testifying today on behalf of the Texas Civil Justice League in favor of House Bill 44. I, along with Steve and Amy Bresnan, on behalf of Texans Campaign for Mothers, were the primary drafters of this bill with Chairman Guerin and his staff. First, let me start by thanking Chairman Guerin and his staff for working with us to ensure that pregnant women who experience pregnancy complications will receive necessary medical care in a timely manner. As stated before, this language in this bill was heavily negotiated between the medical community and the pro-life community. These include the Texas Campaign for Mothers, the Texas Civil Justice League, the Texas Medical Association, the Texas Hospital Association, Texas Right to Life, Texas Alliance for Life, Texans for Life Committee, Texas Catholic Conference of Bishops, and the Human Coalition. So let's talk about what House Bill 44 does. By way of background, Texas has 4 primary abortion statutes. Each was enacted at different times in history, and each uses slightly different language for provisions that are substantially the same. This has led to confusion among the medical community, directly affecting the care provided to pregnant women. House Bill 44 clearly defines what constitutes a medical emergency and then clearly states that a medical emergency is an exception to our state's general abortion ban. A definition of a medical emergency occurs when there is a threat to the life of the mother or a threat to her major bodily function. Making this determination is done by a physician using reasonable medical judgment. That is a standard of care used in all medical cases. This same language is now repeated across the abortion statutes, so there is no longer confusion on what constitutes a medical emergency, and doctors will have confidence to act in a timely manner. This bill also clarifies that in the case of a medical emergency, physicians and hospitals that perform or permitted pregnancy termination will no longer be subject to civil and criminal penalties, occupation, licensure revocation, or a private right of action. There's 2 other significant parts, which are the continuing legal education and the continuing medical education, which will ensure that both doctors and lawyers in this area of practice are well informed by the changes the bill makes. I'm happy to answer any questions.
Thank you. Okay, members, any questions? Oh, I'm sorry, we have one more to testify. I apologize for that. Okay, have you registered as Dr. Deborah Fuller? You are testifying on behalf of the Texas Medical Association, and you are for House Bill 44. Is that correct?
Yes, sir.
Thank you. You may proceed.
Good morning, Chairman Deaver and committee members. My name is Dr. Deborah Fuller, and I am testifying on behalf of the Texas Medical Association with the support of the Texas Association of Obstetricians and Gynecologists, TAOG, and myself. Thank you for the opportunity to testify in support of HB 44 by Representative Guerin, which will clarify our existing laws in regard to medical emergency care for mothers. I'm testifying for this bill because I know this bill will help save women's lives. I'm a practicing obstetrician and gynecologist in private practice in Dallas, Texas. My undergraduate degree is from SMU. My medical school degree is from the University of Texas Medical Branch in Galveston. I then completed a 4-year residency training program in obstetrics and gynecology at the University of Health Science Center in San Antonio. The Life of the Mother Act will bring much-needed clarity to our existing laws to support physicians in providing the best evidence-based care for their patients. This bill presents a thoughtful, necessary step in protecting the health and well-being of women in Texas. I also believe it will go a long way into making OB-GYNs believe they can practice evidence-based medicine in Texas and thus improve our ability to keep and recruit high-quality OB-GYNs and to train and retain these residents in Texas. Retaining these professionals is essential for the health and safety of women in Texas, especially in rural areas where access to care is already limited. HB44 does not change the state's stance on elective abortion. It simply clarifies the law and provides additional protections when physicians exercise reasonable medical judgment to protect the life or the health of a pregnant patient. This should help to provide some comfort to physicians who have feared facing legal consequences for doing what their training and conscience demand. This bill is directed at giving physicians in emergency situations the confidence to do what we're trained to do: save lives without delay and without fear. And most importantly, it helps to ensure that women in Texas can receive timely medically necessary care in the moments they need it most. I urge you to pass this bill to support our physicians in caring for the women of Texas. I'm happy to answer questions.
Thank you. Okay, we will give the members an opportunity to ask some questions. Before we do that, I want to make everyone aware that we do have an overflow room. It is E2036. If you would like to go there, you can wait there until your time to testify. Also, some of the members of the committee have asked me to make sure everyone understands that if they get up and leave, they're going to another committee meeting. It does not indicate that they are not interested in your testimony. So please understand that there will be some flow throughout the day from committee members who have multiple committees. With that, members, any questions? Representative Collier.
Thank you, Mr. Chairman. Just have a clarifying question. Anybody can answer this. You've all provided great information. Does this bill provide any protections to the pregnant patient if an abortion is performed due to a risk of death or substantial bodily impairment of is it major bodily part? I'm trying to look for the language. Function. Thank you.
Representative Collier, I can answer that question for you. Thank you
You're
for
from
that.
the Hospital Association?
I'm from the Hospital Association, yes, ma'am.
What's your name?
My name is Heather De La Garza Barone. I'm an Associate General Counsel. So if your question is, does this bill offer protection to pregnant patients if their pregnancy is being terminated as a result of a risk to her life or substantial impairment of a major bodily function?
Yes.
Took me a while to get that whole sentence out. Yes, it does, in the sense that the bill doesn't actually address that specifically, but already in Chapter 170A, I don't remember the specific section, but it is very clear in Chapter 170A that 170A is not to be construed to allow for the prosecution of the pregnant woman. So it is already in Chapter 170A, and so we didn't need to address that here, and that is not the scope of this bill.
Okay, so there's already protections in place for the pregnant patient so
Yes,
that they
ma'am.
cannot be criminally prosecuted if they have an abortion due to this medical emergency.
That's my understanding, yes.
Okay, all right. And you're saying that this bill, there's already protections in place, and this bill didn't change that at all?
No.
Okay, does anyone have a different opinion that's on this panel? Lisa? No. Okay, thank you.
Representative Alcott.
Thank you, Mr. Chairman. Ms. De La Garza, I have a question. How many women have passed away or died since the Roe v. Wade has been overturned because of this situation?
I don't have an exact number for you, Representative Alcott. I mean, the information that we know to date is what has been reported in the media. The one important thing to remember is that hospitals and even physicians, because of HIPAA, cannot discuss medical cases about their patients unless the patients have specifically authorized them to discuss that publicly. The information we have is
Even if the names remain anonymous?
yes, sir. I mean, you can't disclose there's about 18 identifiers that you are not allowed. If you mention one of those identifiers, you could be potentially violating HIPAA. And our Texas law also says that you have to comply with HIPAA, so it's a Texas law violation as well. So I don't have any specific numbers for you. If I could check to see if that's available, but I think the information we have is the information that's been reported in the media about those specific cases.
Okay. So how about if I ask Dr. Silva, have you encountered any situations where, since 2022, where a mother has passed away because she didn't get the care because the doctor was afraid that performing the abortion, he might get in trouble? Have you experienced that yourself?
Not myself personally, no.
Okay. So I'm just kind of wondering where this, obviously, I think everyone in this room wants to protect the life of the mother, and many of us want to protect the life of the unborn as well. So I'm just wondering where this, came from, and why, and this is for any of y'all, why do we need to change the word life-threatening?
Representative Alcott, I can answer that question. So life-threatening has, as is a modifier in the current law, it has it that it is modifying both the risk of life or death and major bodily function. So the question then becomes, does she in a timely manner have to have life-threatening at that moment in time for the doctors to intervene? That's part of what's going on with these statutes. It's confusing between that. So what the Supreme Court has ultimately said and what this bill does is say, no, it doesn't have to be life-threatening at that very moment. If you can anticipate that she's going to have a risk of death or risk of significant bodily function going forward, then the doctors can, bill clarifies that they can go ahead and intervene.
You mean during the remainder of their pregnancy or later on down the road?
That was the question in terms of life-threatening. It is a temporal issue. So does it have to be life-threatening at this moment, or is it life-threatening 72 hours from now? And this bill clarifies that you don't have to wait for it to actually be life-threatening in the 72 hours from now. You can go ahead and engage.
So that, I think one of y'all mentioned, it might have been you, Dr. Silva, talked about that one of the parts of when you become a physician, that you learn to take into account, you're going to, give the best medical care you can. And I would think that most trained physicians, especially mostly trained OB-GYN doctors, will recognize a life-threatening situation. So that's why I'm just a little confused. So it sounds like is this more of a concern of what may happen down the road? And are there really situations where a doctor said, yeah, this woman, her life might be threatened, but I'm scared to perform an abortion because I might get sued? And I've yet to hear numbers of how common that is, because it seems like it seems like it's at least in the law, as it is right now, that if it's life-threatening, the doctor would have the option to terminate the pregnancy.
I do concur with that assessment. House Bill 44 would enable physicians, based on their sound, reasonable medical judgment, when they make that determination, to act in the best interests of the life of the mother and major bodily function. I wonder if I could have Dr. Fuller, given her clinical expertise, speak to it as well.
You're answering based on if this bill passes. I'm saying as it is right now, before the bill passes, you don't think that the physician has, if a physician believes that because of this pregnancy there is a life-threatening situation for the mother, do they not have the ability to terminate now? Do you think it's really that unclear in the language?
As I mentioned earlier, I'm a physician, not an attorney. It's my understanding that the legal language provided in this bill as filed will provide important clarity to physicians in answer to the question you've proposed.
Okay, and I understand that's your argument. I'm just trying to understand the current situation. I'm trying to understand the mindset of physicians today, OB-GYN doctors, that you portray as being confused about the current language, and that's what I'm just trying to get at.
There are cases of which I'm aware, which have been in the media, that have garnered attention in regards to this subject. I don't know the medical details of those cases well enough to comment meaningfully, but what I can say is no one wants a negative outcome. No one wants a negative consequence. No one wants the death of a mother.
No,
Our
I don't
goal
think
is to
anyone in
make
this room does.
absolutely, and I think we concur on that. And this bill will allow clarifications that will strengthen that commitment.
Okay, thank you.
Dr. Fuller.
Representative Frank.
Thank you very much. I'm curious, either personally or your organizations, how many patients are there at this point? Because I've heard, meaning, is there one or two? And then follow-up to that is, how do you balance those two? Is there one patient, the mother, or are there two patients, the mother and the baby? From your organization standpoint, because you mentioned some things about doctors being able to practice based on what they think. Well, if you think there's only one patient, so I'm just curious how many, what does your organization think? Is there one patient or two patients in this situation? And then how does the bill balance those two?
Sure. The TMA is committed to providing the best care possible to the mother and the fetus which she is carrying. That is the nature of who we are as
by calling it a fetus, you're saying there's not a patient there, right? That y'all's position is that's not a patient.
Clarify the question. When you say a patient in the sense of,
Is there one or two patients at time of, in these situations, is there one patient or two patients?
we are committed to taking the best care possible of that mother and that fetus. So if that would
So there's one
qualify,
patient.
if that would qualify as a patient under the definition you're proposing, we would be in support of that. We're absolutely committed to maternal fetal health at every stage of pregnancy, including immediately after delivery and thereafter.
Okay, I didn't think it was
No.
So there's one patient, according to you? Because
not-
to me, that's
No,
what
it's a
we're coming down to in this bill, is trying to figure out where that balance is. And it's really tough. I'm not trying to, it's a really tough thing, because we want to protect both, and we want to favor, I think, most of it, the mother or the one that is there. But if there's, I'm just trying to figure out what responsibility your organization feels like there is to the second. And
So Representative Frank, I might be able to answer the question for you. So in this bill, we put in a new section 170A.022, which is basically what you're asking. So in that case, it says that the obstetrician needs to act in a way that if they're treating a pregnant woman, that would sustain the life of the child, unless doing so would provide a negative impact on the risk to the mother, whether death or reasonable bodily injury. So that's a new section in here. It says here, a physician who treats a condition described in 178.002B2, that's the new definition, or the definition of medical emergency, shall do so in a manner that in the exercise of reasonable medical judgment provides the best opportunity for survival of the unborn child,
Okay.
unless doing so is a negative impact on the mom.
And the negative impact on the mom,
Is risk of death.
Can that include mental anguish? Can that include?
No, sir.
Okay.
It's risk of death or serious bodily function,
Okay.
which is a physical condition under the current statute, and that contains in this bill.
Okay.
Does that answer your question?
Yeah, it doesn't answer the one or two patients one, but yeah, that answers that question. Thank you. Because I know you use plural on patients, but then never talked about the second patient. And I'm done.
When we have a patient in the hospital, we have someone admitted under a name. We don't have the unborn child admitted at that point as a patient, but we consider both until there's this end-of-life care issue, and we consider them both very seriously. Again, we are blessed to have the amendment that offers the exception to clarify that women diagnosed with a major health issue, and that could be cancer, that is going to terminate their life, and they can choose to now receive treatment to terminate the pregnancy if needed to prevent the harm to the mother.
Representative Frank.
Thank you.
Representative Frank, may I also add something to it? I think it's very important for all of us, you members, and everybody in this room, when these situations arise, these are all wanted. This is not a choice bill. It is just to ensure that all of the language is clear when it comes to liability. Like, what am I allowed to do when her life is in danger or her major bodily functions in danger? As Ms. Kaufman stated, we are required by law to take, the physicians are required by law to take any action they can to ensure that, give the opportunity to the unborn child, fetus, whatever your political stance is, to survive. And so I think that's important to remember. And the other thing to remember is hospitals and the physicians that practice in them, it was a medical standard of care, and they were treating these patients as a result of pregnancy complications. Obviously, the definition of abortion, includes what was happening in hospitals and the physicians making these decisions. That was about 1%. Now, as a result of all of the laws that have gone into place as a result of the Dobbs ruling, the majority of these complications are now happening in hospitals. And so we went from kind of something that you never had to call a lawyer about or anything to you had to make sure, doctors felt the need to make sure that they were acting within the scope. And so that is all we're trying to do today. And I think the law requires us to ensure and take all actions necessary, to protect the unborn child's life, but you are not required to do so if it risks her life or her major bodily functions. I hope that clarifies everything.
Thank you, Chairman. Okay, Representative Pearson.
Thank you, Chairman. Good morning. Thank you all for your testimony. I'm going to echo a little bit of what Representative Olcott was getting at. I completely understand from a liability standpoint on a physician making sound, reasonable medical judgment. And this is for either of the doctors on the panel. Representative Olcott mentioned the expectation was that a physician would recognize a life-threatening treatment. So if the goal is just to remove liability for making your sound, reasonable medical judgment, why do we have to strike the life-threatening language in order to do so? Because it seems like everything seems to be fine as long as you can function within your duties of making reasonable and sound judgment. And then I'd like for you to also give the committee examples of what impairment of a bodily function would be in the form of a diagnosis.
Do you want to break down the questions? Because there's two different ones.
First, if the issue is liability that's preventing you from making reasonable, sound medical judgment, why do we have to strike life-threatening?
Right now, physicians who care for women in emergency medical situations that have to do with these situations are confused. They don't always understand the law at that moment. They don't understand the nuances of, am I going to be prosecuted? Am I going to lose my licensure? Am I going to have criminal or civil fines? That's part of their fear currently, and without having, in an emergency situation, without having that knowledge, there's fear and there's care for the patient. This bill, HB44, is to clarify that. Help physicians in an emergency situation, help hospitals to help physicians in an emergency situation, help attorneys to help hospitals to help physicians in these emergency situations.
So
Clarity will be so important.
that's kind of my point, though. If the liability itself is removed and you're allowed to make the decision that you believe is the right decision to make at that point in time, why do we have to change the language of life-threatening? Because that's no longer an issue if the penalties and the liability is removed.
Representative Pearson, if I could answer that for
Yes.
you. So the life-threatening in the current statute modifies both the risk of death and the risk of major bodily function. You can have a risk of major bodily function that is not life-threatening. And the medical board and the Supreme Court has said that includes future fertility. So future fertility, although very sad, wouldn't necessarily be life-threatening. Another instance would be if you have a situation where a woman has, in carrying this, would increase or have some kidney failure. You can live with one kidney. You can also live on dialysis the rest of your life. So it wouldn't be life-threatening, but it certainly would be a risk of posing a risk to a serious major bodily function, and that's why life-threatening was struck from this. So the risk of death, obviously, is life-threatening. That would be analogous to each other. It's the serious bodily function that doesn't have to be life-threatening, but certainly could be severe.
So then we are, with this bill, approving abortions that are not life-threatening. And then the impairment of major bodily function, as you just said, is probably in the future.
Not necessarily.
I would disagree. I think what we're trying to do, our understanding from the beginning is that it is those two scenarios that have always been what has been protected. And what has been confusing is the fact that whether or not that term modified those two situations. And I've always understood it to be it's one or the other. I've never understood it to be just the life of the mother. But I think because of the way the wording is written, that is why there has led to confusion. The other thing, too, is prior to even the Cox case, and the Cox case was in re state to be for the legal people in the room, and then there was the Zarowski case. Prior to both of those cases, life-threatening is not defined in that statute. And so when you're faced with being charged with a first-degree felony, what are you going to do? That's just going to change behavior. The whole point of a criminal law is to deter and to change behavior. And so rightly, like, right or wrong, people got scared. And so I think when they were faced with these situations right out of the gate, kind of like no guidance out there, they waited until they felt they could be absolutely sure they could defend this to a prosecutor, to a court of law. Again, right or wrong, we're not here to, that is what happened. Additionally, you get the Cox case and the Zarowski case, and it wasn't until those opinions came out that we first had guidance or clarity from the Texas Supreme Court, someone that, when they issue opinions, that is the common law, that is the law of this state, to say that life-threatening does not mean imminent. And so the other thing about that term, when it's not defined, it's, the plain language and the meaning of the term. Zarowski case kind of talked about that, it's risk of death. And so what they're saying is risk of death or major bodily function. The medical board in their rules also seem to distinguish that there are two scenarios, and that is it. It is risk of death, substantial impairment of major bodily function. The other kind of confusing thing and why we're trying to memorialize what the Zarowski case, was holding in the point of imminence. And so one of the other components about removing life-threatening is to ensure that this imminence issue isn't an issue anymore. And so because court cases can be overturned, we take that off. And so risk of death is life-threatening, and then you have substantial impairment of major bodily function. I have never understood that it's just one. I've always understood it's both.
So what is some impairment of major bodily function?
Loss of fertility, and the physicians can probably speak to that.
If a woman has a cancer, a breast cancer that requires chemotherapy. Currently, I can think of a case of a woman who has colon cancer. Her treatment would involve chemotherapy and radiation to a fetus. Dr. Silva might be able to speak on the dangers of radiation to the fetus. If she avoids these, the woman has a choice, but if she avoids her treatment, her life expectancy is reduced. Death from her cancer may occur even before the pregnancy is over. So that would be loss of bodily functions.
Cancer and radiation aside, I think what we're trying to figure out are what are the major issues that could arise in a situation like this that would fall into the diagnostic category of major impairment of bodily function. Dr. Silva?
No, and thank you for the question. I think the example given earlier was renal failure.
Okay.
Imagine a scenario where there's an obstructive nephropathy, the kidneys start to fail, and the decision is, do you commit that woman to a lifetime on dialysis or make the difficult decision regarding the exception to the abortion and the ability to do that? You could also imagine a scenario where there's premature rupture of membranes and there's infection and the patient becomes septic, hypotensive, and there is a point there. First of all, she is sick from the beginning of that. But there is a point where you go into multi-organ failure where it's sort of the point of no return, and we don't want to get to that point. We want to be able to address that woman's life at that moment in time. Now, granted, to your question, that's the life, but when you start getting into multi-organ failure and you see not just the kidneys failing, the liver failing, even potential for brain injury, the circumstances become very important for we as physicians to make that appropriately, and we think these exceptions will allow us to make those decisions.
And in your opinion, is that just doing a blood and urine to determine elevated labs to make that decision, or are there multiple checkpoints to determine whether or not this is a serious condition?
Every patient is different, every circumstance is different. What we do as physicians is we apply our medical judgment to multiple factors. Unquestionably, the patient in front of us, unquestionably her symptoms, but to your point, laboratory studies, imaging studies, her past history, obstetrical ultrasound. It's a multifactorial decision-making, which I think is why we're not listing 20 individual conditions. We're allowing the physicians, based on their judgment and their experience, to make a decision for a patient who is by definition unique.
And so by eliminating your liability, but keeping the life-threatening language intact, would that impair you to make those decisions with those labs, with those diagnostics, if this liability is removed?
We're always going to make the best decision for our patient.
That's not what we're hearing, though.
We are committed to that goal.
Apparently, the purpose of the bill is because we're being told that physicians are not exercising their best judgment in fear of liability. So my question is, if we just remove that liability and allow you to just practice your medicine, is that enough? Or do you think that changing the language somehow changes your ability to do your job?
I think we want consistency. We just want to know.
Okay.
We just want to know when we're going into taking care of these patients that there's consistent guidance. Again, we're not lawyers, we're doctors. We rely on others to help us understand these circumstances. And I think what I heard from the two attorneys at the table is that this bill will enable just that. Consistency, so our physicians are more comfortable and confident taking care of this important group of patients.
Thank you.
No, thank you.
Representative Simmons.
Thank you for being here. I think it's really unfortunate that we're having to sit here and have this conversation, that professionals are not able to do the jobs that they went to school and trained for, because people like me, who are the most special of the 150, people representing this in this body, who some of us are doctors, but most of us aren't. And some of us may have personal feelings about the way healthcare should be, I guess, administered, but that's really not our professional capacity. I have a hard time sitting here and listening to y'all be drilled this way. It frustrates me because I remember having to make hard choices. I've had 2 very difficult pregnancies, and I remember being on the way to the hospital and my husband and I having the conversation, if I have to make the call, what do we do? And as a mother, you always are gonna say, pick the baby, because this child is wanted. And having to go back and forth and think about the other child that you have at home or my future fertility. I got my tubes tied after my 2nd pregnancy because it went so poorly that I could not take a chance and risk getting pregnant again and maybe not being able to make the choices I needed to make. I'm going off tangent here, but can you talk to us about timing, right? How quickly these doctors have to make those decisions when a patient comes in with sepsis, or they come in and they're bleeding out. Because I'm reading a story right now where a woman was 11 weeks pregnant and she is bleeding profusely. Her mother is with her, who's a doctor, and is asking, why is no one doing anything? And that she was passing blood clots the size of grapefruits. This is a woman who had other children at home. This is a woman who may have wanted to have more kids. And she was sent home because she wasn't close enough to death. Can you walk us through that time frame and that decision-making, that split-second decision-making, that doctors may not have an opportunity to call an attorney or second-guess themselves, and what that means for the life of a mother?
Let me start with, you started talking about the sepsis first. You have to get to the definition of sepsis. If a mother walks in with preterm rupture of the membranes and does not have a fever, can we just watch her at that point? Certainly we can. How long we can watch her then is determined by other things that may start to happen. The cascade can happen slowly. The cascade can happen quickly. An elevated white blood cell count, fever, an elevated lactic acid. You start getting then the diagnosis of sepsis. We activate a sepsis protocol. We increase her fluids. We do the right things by starting antibiotics.
Where is the decision-making then if this woman has preterm premature rupture of the membranes? Is she, unfortunately, in prior cases, sent home when possibly she is febrile because doctors are so confused about, can I make this decision now? Do I have to wait? We want the ability to make the decision when this woman's life is in peril. And we want to be able to have the confidence, the backing of our hospital systems, the backing of attorneys to help us to make the decisions and make them quickly. Hemorrhaging. A woman can be bleeding and have a stable hematocrit, blood count, that shows that she is not anemic yet. Can we watch her? Can we see what happens? We want to have that ability to continue to watch, but if that blood count drops, we start having to give her blood products. We are then in the possibility of DIC, her platelets falling, clotting mechanisms are going crazy. We have to act because this is putting her life in peril. I hope that helps. Other questions?
Thank you. That was very helpful. Anybody else that wants to expand that can, but I thank you. That was helpful.
Okay. Representative Busey.
Hey, Mr. Chairman, I want to start by thanking Dr. Fuller, who is my mother's doctor and has taken care of her for many years, and our family appreciates it.
Thank you.
This is a great follow-up because I was going to ask you to take us into the room of what Rep. Simmons just talked about and why we need clarity and we don't always have time to stop and call a lawyer to save the life of mother. I think you just answered that well. I don't know if you have any more elaboration on kind of taking us into the moment of these situations and why that's important that we have that immediate clarity. If there's nothing else to elaborate on that, I'd love to hear more, Doctor, if you have some. But.
No, one important part of the bill is the communication piece, is for the physicians to feel comfortable communicating with the patient, certainly, if necessary, to communicate with some legal counsel in a challenging circumstance. All of that is protected from aiding and abetting an abortion. To your point, Representative, time matters. Time absolutely matters. And we have to make decisions quickly on these patients because to the clinical circumstances that were just described, these patients can change quickly in a moment. And we have to be on top of that. We have to be able to make decisions. And we absolutely have to be in a position where we can make those decisions with absolute confidence and clarity.
Let me ask, you all have looked at this bill. Do you feel in your practice that if House Bill 44 becomes law, you will now feel that legal clarity that you needed to go protect and take care of women and the women in need in an emergency situation?
Yes.
This bill will satisfy that requirement from y'all's end.
Yes.
Let me go a little bit further. I have 2 children's hospitals in my district. I have lots of pregnant women that I serve as constituents. They are living in this state in regular fear of pregnancy complications and where they're at. Tell me that House Bill 44, if it becomes law, I will be able to go back to my constituents and reassure them that their life will be protected to the best of our abilities under this law. Do you agree with that?
Yeah, I'd let Dr. Fuller expand on that from a clinical perspective, but the answer to your question is yes. Our ability as physicians to use sound medical judgment to make these important determinations with confidence and clarity is relevant, and this bill satisfies that. Dr. Fuller.
I agree. This bill goes a long way to taking a burden off of our shoulders when we are in crucial situations with decision-making, possible end of life for mothers. I think I can feel confident talking to my patients and saying, look, we now have the backing of the Texas legislature. We have the Texas Hospital Council. We have attorneys. We're going to have education through our Texas Medical Board in conjunction with legal. We have some confidence to act to protect you under these circumstances. Whereas before, I don't want to say our hands were tied, but we felt so constrained. What should I do? How do we manage this? We don't want to continue to live like that, trying to take care of mothers in the state of Texas. And I was going to answer the question about the numbers. Any mother who dies unnecessarily is one too many in the state of Texas.
I agree with you fully. I appreciate y'all being here, taking us into the room of why it's so important that we don't live in a gray area around this decision and that we're able to readily protect the life of the mother. So thank you so much.
Thank you.
Thank you.
Okay, Representative Schaffner.
Thank you so much. Quickly, I just wanted to clarify. I've heard that doctors are confused and the potential of. So are you saying that the TMA and the Hospital Association do not have any numbers on the amount of cases that have happened so far in these past years?
Representative, when you say the numbers, clarify the numbers you're asking. I'm sorry.
The,
just to
the numbers of women where these situations where I know y'all are confused and you don't want to, you're afraid of the liability. So are there any cases where the women have died and you all got sued, or the baby had died and you all got sued, or is this just in case? I just want to clarify for this bill.
Yeah, I'm not aware of a circumstance where a physician has faced the consequences I described, specifically jail time or the like. I referenced earlier there are cases which are in the media. Again, I don't know the details
besides the
medically.
media.
Besides that, but just from an objective yes or no perspective, I'm not aware that that circumstance has occurred. Thank you.
And I'm not aware of specific numbers of the amount of cases. I can tell you, and this has been in the media, but there have been hospitals that have had violations of EMTALA complaints filed against them.
Say that again.
Violations of EMTALA complaints filed against them with the federal government. I'm aware that that's public. That's they filed they violated EMTALA for not acting. I can't remember if the woman in those cases passed away or not, but that has happened. I don't know the status of those investigations because that's at the federal level. And I don't know about the number of lawsuits. I mean, lawsuits are all public, so we'd have to go and check. But I don't have specific numbers of the amount.
All right, thank you.
Representative Alcott. Okay. Representative Schofield.
Good morning. Thank you for your testimony today. I don't think anybody that I'm aware of is opposed to making sure we have clarity on actual emergency situations. But I think that a lot of the pro-life community is worried that when you start making exceptions, they'll become check boxes to just get around and get right back to elective abortion on demand. So as people who negotiated this bill, and I understand folks on sort of all sides of the spectrum were involved in working on the language, if you could tell me and the public who's listening what's in the bill that protects against that, and if you would start, I know you know the language of the bill, Lisa, better than the other folks, and the doctors can talk off of how you explain the law.
Sure. So the bill clarifies that the risk of death is one situation, and then it clarifies that the risk of bodily function is the other. Now, the medical board and the labor code define what major bodily function is. They include things like immune system, normal cell growth, digestive, bowel, bladder, neurological, brain, respiratory, circulatory, endocrine, and reproductive functions. Those are already existing in the law, so that defines what kind of a major bodily function is. What our bill does is bring it back to the physician to figure out in a timely manner, so imminence is no longer an issue, whether or not there's a risk to her or whether there's a risk to her major bodily function, as already defined in the law.
Right, but when abortion was legal, the abortionists were physicians. So what prevents just getting around the intent of the law by just having abortion on demand, them checking the box going, yes, the major bodily function could be at issue? And I'm sure, again, since everybody is in agreement on the bill, I'm sure it's in here. Can you explain what it is?
Okay, so first and foremost, 170A prohibits abortions in Texas, except in 2 cases: risk of death, substantial impairment of major bodily function. That is it. That is the law. Hospitals are not licensed abortion facilities. We are hospitals. We treat emergencies, we treat acute care. There is, there's a chapter that had like that before Dobbs came down, that was a regulation of abortion facilities, and hospitals were specifically exempted. And so if the only legal permissive, if you will, pregnancy terminations, a majority of those will be happening in hospitals. I think there is protection to the extent that if there is a medical emergency, as that is defined, in an unlicensed abortion facility, that is protected too, because we want to make sure that if someone starts bleeding out in a clinic, they can get the care that they need. I don't think there's anything in here that says an elective abortion where there's no risk of death, no risk of substantial impairment of major bodily function is present, that is allowed or prohibited. I don't think any physician would, in practicing in our hospitals would make that decision, nor would the hospitals have any policies that would allow that. We never did before.
Additionally, we don't change the law with respect to reporting. So anytime that there is a termination within the hospital setting, or they're still going to have to report it, they're going to still have to document it. So that is your catch-all to determine that there is a reasonable medical judgment that there's a problem of either death or serious bodily injury.
And I would presume if an off-site physician, not in the hospital, is suddenly reporting a whole lot of life-threatening cases, that would kind of tend to let the agency know something's going on.
Correct. The provisions in here about an unlicensed facility really is dealing with rural Texas. Obviously, we have a lot of places in Texas where you're more than 200 miles from a hospital. And so if you're bleeding out and you have the opportunity to go to a doctor's office or a clinic in a medical emergency, that just allowed them to take care of it.
And there's also a provision in one of the sections, I don't remember where it is, regarding the medical treatment, where we're clarifying that there's no requirement that you alter, delay, or withhold. There is another subsection in there that says, however, this section cannot be construed to allow for a prohibited abortion under Texas law.
Doctors?
Thank you for the question. We practice in this state. We love this state. We are citizens of this state. We respect the laws of this state. I cannot imagine a scenario where a physician, based on our high ethical and moral standards, would check a box just to enable their ability to not follow the law. And I can say that with confidence. Thank you.
I agree with what Dr. Silva has said. The phrase elective, especially that word elective abortion, has to be looked at, and this HB44 maintains the current prohibitions against elective abortions. What we have talked about this morning and discussed this morning have no relationship to elective abortions.
Additionally, the criminal, civil penalties, and honestly, the private right of action still remain intact if you're talking about an elective abortion. This bill doesn't protect them from that.
Yeah, I mean, the main goal is to prevent delay. That is an overarching theme of House Bill 44 and its Senate companion. By the clarity, by making sure that we outline what is not aiding and abetting, it is preventing delay. It's people don't have to stop and be afraid. That's what we're trying to do here.
Thank you.
Representative Johnson.
Thank you, Chairman. Dr. Silva, and I appreciate the comments that just came out of this panel with regard to Representative Schofield's. We are not talking about elective abortion.
Correct.
This bill is not about choice.
Correct.
This bill is purposely a bipartisan bill addressing an issue of medical exceptions. Because if it were not, we would be talking about rape or incest or fatal fetal abnormality. This is not a choice bill. This is a medical exception bill, correct?
It's a bill about medical care, correct.
About medical care, and it is attempting to separate us from a highly politically charged debate. And so I want to talk about that, if you don't mind.
I don't mind.
You are not an activist.
Correct.
You're just a straight-up physician. You are not ready to go to prison to serve a political point.